Hello. Today we are going to go through chapter 15, the autonomic nervous system. So first thing we're going to do is we're going to compare a little bit about between the autonomic nervous system and that somatic nervous system that we've talked about. The somatic motor system, somatic means muscle, so they are motor neurons. Motor neurons, so they're going to innervate those skeletal muscles. So when a somatic motor neuron goes to that skeletal muscle, it's going to contract. It's going to cause excitation of that skeletal muscle, and it's voluntary. That somatic nervous system also receives sensory information. That sensory input, because we need to know what is happening around us. That tactile, thermal, pain, proprioception, or even those special senses like sight, hearing, taste, smell, and equilibrium. This is all information that is coming into that somatic nervous system that may or may not send out a response. So that autonomic nervous system. This is a nervous system that regulates cardiac muscle, smooth muscle, and glands. This is something that we do not have control over. The responses are these visceral effectors. So visceral means it's going to affect the viscera, your chest and abdomen. So we're going to have autonomic neurons. They're going to help regulate visceral activity. It can either increase by exciting, it can decrease by inhibiting. So some examples from your textbook. Changing that diameter of your pupils. When it's darker out, your pupils get larger so you can see better. When it is brighter light, your pupils get smaller because you don't need as much light shining into the back of your eye. Dilation and constriction of blood vessels. When you're running, your blood vessels are going to dilate. When you're laying in bed, your blood vessels are going to constrict. They'll get smaller. That autonomic nervous system will also regulate the rate of your heart. It can speed it up, it can slow it down, and the force of that contraction. How much is that heart pushing that blood out of the body or out of the heart? The difference between this autonomic nervous system and with your skeletal muscles, something that is innervated by the autonomic nervous system will function even if their nerve supply is damaged. You'll go into more detail in anatomy too, but that heart has their own pacemaker cells. So that heart is going to maintain that own rhythm. This is why hearts, when they're removed for a transplant, they're still going to contract. The autonomic nervous system will function without your brain knowing it. We mentioned in the brain chapter, most of your autonomic functions take place in the brain stem. Things that are regulated in the brain stem, we cannot control. We can only control what goes up to the cerebral cortex. We only consciously know what is happening once it's reached that cerebral cortex. So you cannot consciously control your heart rate. But here's some people who practice yoga and certain meditation techniques. They can learn how to regulate some of their autonomic activity. It takes a lot of practice to be able to do this, to make their way through lie detectors. But since autonomic activities are something that we cannot consciously control, this is why lie detectors are pretty reliable, because there's certain autonomic functions that tend to happen when you're lying. We have different ways to monitor for this biofeedback what is happening in the body. We've got that heart rate or that blood pressure. We have this biofeedback that can help to maintain a certain heart rate or a certain blood pressure. So there's sensory input coming in from interoceptors. Interoceptors inside the body. So they're in blood vessels. They're monitoring your blood pressure. They're monitoring your blood chemistry. We have these receptors in visceral organs. We are monitoring the internal environment with internal receptors. So we're monitoring that carbon dioxide level in our blood. We're monitoring the degree of stretch to the different organs or blood vessels. These interoceptors are taking in this information and sending it into the brain. So if it needs to be altered, this information can be sent back out based off of this input. So this is a really nice chart that just from your textbook that goes through and compares that somatic nervous system to that autonomic nervous system. That how sensory information comes in, motor pathway out, what kind of neurotransmitters or hormones, what the effectors are, what the different responses are. So in our autonomic nervous system, we have this sympathetic, the fight or flight. This is preparing the body for some sort of emergency situation. We also have the parasympathetic nervous system. This is that rest and digest. We are working to conserve energy and restore energy after you put your body through some sort of stressful event. So most of our organs have both sympathetic and parasympathetic. That would make them have this dual innervation. One is going to increase the activity while the other will decrease the activity. And it depends on what the organ is, on what is increasing versus decreasing. Like the sympathetic will increase your heart rate, parasympathetic will decrease your heart rate. But in your digestive system, the sympathetic slows down your digestive tract while the parasympathetic will speed it back up. Same with the kidneys. The sympathetic will slow down or prevent filtration of too much material or too many fluids and ions and waste products. Because the last thing you want to do in a sympathetic fight or flight type of moment is go to the bathroom, have to stop to pee. So we're slowing things down for that sympathetic. We regulate it back to a normal rate during parasympathetic. Then we have that enteric plexus. Again, we mentioned it in chapter 12. It's back. This is lining that digestive canal. Again, it is involuntary. We do not have control over this. And it's monitoring the different chemical changes in the digestive tract. So we mentioned that in the somatic system, there's usually a single neuron that is coming into the spinal cord or going out. The autonomic nervous system has a two motor neuron series. So that first neuron, its cell body is in that central nervous system. It's either going to be in the brain or the spinal cord. It's going to leave on a myelinated axon from that central nervous system. It's going to go to an autonomic ganglion. So it's going to go synapse with another neuron in this autonomic ganglion where cell bodies are found. That second cell body is in that autonomic neuron, and then it's going to leave on an unmyelinated axon to its effector. Smooth muscle, cardiac muscle, or glands. So some of these autonomic pathways have specialized cells like chromaffin cells that are found in the adrenal medulla. In the adrenal glands that sit on top of the kidneys, the medulla is in the middle. And these cells make epinephrine and norepinephrine. They're a neurotransmitter. They also function as a hormone. You'll learn about in anatomy too. So these autonomic motor neurons, they're going to release either acetylcholine or norepinephrine. So whenever we have the somatic motor neuron, there's this one neuron that travels the entire length, then it's going to release that acetylcholine at that skeletal muscle. Well, here we're looking at autonomic. So we have that one neuron myelinated that is going to that autonomic ganglion. We release out that acetylcholine, which is going to allow this sympathetic neuron to go to its effectors. We can have this one preganglionic neuron. It's preganglionic because it hasn't gone to its ganglion yet. This time we're going to the adrenal glands. So at the adrenal glands, we're going to cause these chromaffin cells to release out that norepinephrine and that epinephrine into the bloodstream. And we're going to use that acetylcholine to make it happen. Now we have parasympathetic preganglionic neuron. Again, it's going to release out that acetylcholine when it gets to that autonomic ganglion. Here, we're going to go to our effector cells and we're going to release out acetylcholine again. So norepinephrine and epinephrine tend to be used more in the sympathetic because that's going to cause more norepinephrine and epinephrine as those hormones or neurotransmitters that cause that more sympathetic type of response. Acetylcholine is used by this parasympathetic over here to cause that rest and digest type of response. So we have that two neuron series I mentioned. We have the preganglionic neuron. So this is the first. It is going to go and synapse in an autonomic ganglion. Their cell bodies are in the brain or the spinal cord. Our postganglionic neuron here starts at that autonomic ganglion. From that autonomic ganglion, it is going to go to its effector tissues. So this post-autonomic or postganglionic, the entire neuron, cell body, and everything is outside of the central nervous system. Their cell bodies are in that autonomic ganglion, and they're going to terminate at their visceral effector tissue. So these preganglionic neurons have that information from the central nervous system. Those postganglionic neurons are going to send that information to those visceral receptors. So there's a two neuron series in the autonomic nervous system, and that's what makes this different than the central nervous system, the somatic nervous system. So let's look at our preganglionic neurons. Again, their cell bodies are going to be in the lateral horn of the gray matter in that spinal cord. It is found in the 12th thoracic and the first two lumbar segments. So this is the thoracolumbar division. This thoracolumbar division is our sympathetic neurons. This thoracolumbar outflow are the axons of the sympathetic preganglionic neurons. We have our craniosacral division. This is parasympathetic fibers. So we only can get parasympathetic fibers if these axons come out of the cranium or the sacrum. Sympathetic are only going to come out of that thoracic. That's what I was looking for because I was trying to, thoraco wasn't right. Thoracic and lumbar areas will give us sympathetic. So we have a sympathetic trunk, which is an entire chain of ganglia where these sympathetic neurons, these preganglionic neurons, and these preganglionic neurons enter these ganglia, these postganglionic neurons leave these ganglia. We have superior, middle, and inferior ganglia, which are sympathetic. We have prevertebral or collateral ganglia. So they run anterior to that vertebral column. So we have, these are all ganglia, all of these little enlargements here. This is this superior cervical ganglion. It's fairly large. But then when you get to the thoracic, you have one. These are all individual ganglia at each individual level. So let's look at some of these sympathetic ganglia and where they are found. Some of them have specific names, like the celiac ganglia. This is by the celiac trunk, which is a blood vessel that comes off of the abdominal aorta. You'll see that in anatomy too, but it sits just below the diaphragm. We have a superior mesenteric ganglia. It is by the superior mesenteric artery in that upper abdomen. We have an inferior mesenteric ganglia. It is by that inferior mesenteric artery. That's at the middle area And then we have this aortico-renal ganglia. It's by that renal artery. And then we also have renal ganglia. So it's by that renal artery as well. So we've got a lot of different ganglia scattered throughout. So let's look at some of these. This is just the sympathetic, the thoracolumbar. So you can see all of these blue dots. Those are sympathetic cell bodies that are leaving the spinal cord. You see, they only come out T1 through about L2, L3 area. So if they're traveling further than that, like up to the face, they need to, when they leave, they synapse in a sympathetic ganglia, they're going to travel up. Or they can travel down those different ganglia to get to the level they need to go out to their specific effector organs. So that parasympathetic. The parasympathetic, their ganglia is either close or within the wall of their visceral organ that they are going to have an effect on. So there's a ciliary ganglion. This is by the eyes. Pterygopalatine ganglion. This is by the mouth. Submandibular. This is below the tongue. Otic by the ear. These are the ones that have specific names. The parasympathetic, those preganglionic axons are a lot longer. Those postganglionic axons are short because the ganglia that they are going to is right next to or in the wall of their effector organ. So here, that parasympathetic is that craniosacral. So you can see these are coming out on some of these cranial nerves, and they are going down to their specific effector, that vagus nerve we mentioned in the last chapter, chapter 14, comes down to the heart, the lungs, the liver, the stomach, part of the colon, the small intestine. You can see, I should have drawn that in there as well. So you can see all of these red dots here. This is where a ganglia is at. So these nerves that are coming out of that spinal cord, they are traveling all the way to their effector organs before they hit that ganglia. And then we have the pelvic splanchnic nerves. These pelvic splanchnic nerves are carrying that parasympathetic out of those sacral nerves that are going out to mostly pelvic organs. Anything that's in the pelvic area is coming out of these, or getting their parasympathetic from the pelvic splanchnic nerves. So preganglionic neurons are going to go through that sympathetic trunk. They may connect with a postganglionic neuron. There's 4 different ways they can do it. So they can synapse with that postganglionic neuron in the ganglion that it first reaches. So the first place that it stops, it can synapse with a neuron there. It can ascend or descend to higher or lower ganglia before synapsing with that postganglionic neuron. It can continue through the sympathetic trunk ganglion to end at the prevertebral ganglion and synapse with a postganglionic neuron there. Or They may pass without synapsing through that sympathetic trunk. And then they extend to those chromaffin cells in the adrenal medulla. And in that point, they're releasing out that acetylcholine to release out that epinephrine and norepinephrine into the bloodstream. So a single sympathetic preganglionic fiber has many axon collaterals, or a collateral is a branch that where it's going to come back again. And it may synapse with 20 or more postganglionic neurons. This is that divergence that we looked at in chapter 12. And this is why sympathetic responses affect most of the entire body, because that nerve is going to branch out and go all over the place. That parasympathetic, on the other hand, they're going to go through the parasympathetic ganglia, and they only usually synapse with 4 or 5 postganglionic neurons. Parasympathetic responses are more localized. So we've got some autonomic plexuses, which again are those branching of those different nerves in different areas that are going to help do their job more efficient. These autonomic neurons do their job more efficiently because they're connecting to more neurons. So the main ones that we have a cardiac plexus. That goes exactly where it says it does. We have a pulmonary plexus. The lungs, the bronchial tree. Then we have a celiac. Celiac for abdomen or stomach. This is the largest. The celiac plexus actually goes most organs in the stomach, even into the pelvic area. We have a superior mesenteric ganglia. Goes to that small and large intestines. We have an inferior mesenteric plexa. Goes to that large intestine. We have a hypogastric. It's at that 5th lumbar vertebrae area. Goes to that pelvic viscera. And then we have a renal plexus. Has that renal ganglion, kidneys and ureters. So if you remember a lot of your anatomical terms from chapter 1, these anatomical terms are telling you right where these plexuses are located. So here's what some of these plexuses look like. I have actually seen these in a cadaver before. It is really cool to see how these nerves just all branch. As you can see, this cardiac plexus is all in where the lungs would be sitting. There's this celiac plexus, the superior mesenteric plexus, the inferior mesenteric, and that hypogastric plexus. So you can see how it's just this chain of nerves that are supplying all of these different organs in the area. So how do these nerves get to these autonomic ganglia? So from the spinal cord, I want pictures. There we go. So in these pictures, we have this spinal cord. This nerve is coming out of the spinal cord, traveling on that spinal nerve. And here's the difference. Instead of continuing on, it is going to come into this autonomic ganglion or sympathetic ganglion. What it is traveling on, that's where it's labeled, I just wanted to highlight it, is known as this white rami or white communicating rami or white rami communicants. Same thing. This is named a white rami communicants or white communicating ramus, sorry, because we have myelinated axons coming out of that spinal cord. So it's white because they are myelinated. Now that there's different pathways these can go. This nerve can continue to another ganglion. It can travel up to a different ganglion, or it can leave that and go back right out on that spinal nerve. What it leaves, if it's going right back to that spinal cord, or spinal nerve, sorry, it's on that gray communicating ramus. It is gray because now we have unmyelinated axons. That's why it's gray. So there's pathways for these nerves to travel depending on where they are going, but they're going to go to the sympathetic trunk through either this white or gray communicating ramus. So back up here, we have that white ramus, that white communicating ramus that is going to go to that sympathetic trunk because they are myelinated axons. That sympathetic trunk is going to run the entire length of that spinal column. There's 3 cervical, 11 or 12 thoracic, 4 or 5 lumbar, 4 or 5 sacral. And there's 1 coccygeal. So it's going to run the entire length of that spinal column. It runs on either side. There's a left one and a right one. That superior cervical ganglion is going to the head and the heart. That middle cervical and inferior cervical, heart and blood vessels of the neck, arms, and shoulders. So the thoracic portion is going to be pretty close to those ribs. They're going to go to sweat glands, blood vessels, those erector pili muscles, and the hairs in our arms are going to go to the heart, lungs, bronchi, thoracic area. The lumbar and the sacral are kind of going to go to those organs that are in that specific area. So, as I mentioned, they can go different directions. I drew some of it out, but they can enter right back into those spinal cords. They can form cephalic para-arterial nerves. They can form sympathetic nerves, or they can form splanchnic nerves. So that gray that I said, that gray communicating rami, gray because they're unmyelinated. There's more gray than white. And depending on where they synapse, they're tending to go to the tissues or organs in that specific area. So the cephalic para-arterial nerves, cephalic means head, if you remember from chapter 1. So they're going to leave that sympathetic trunk and they're going to go into the head. So they're going to be visceral effectors of the skin of the face and the head, that's sympathetic. So the face, well, you sweat. A sympathetic response, we'll go through it in detail, but that sympathetic response, you get sweaty during a sympathetic response. So those sympathetic nerves, they are going to go through that 1st through 4th thoracic ganglia if they're going to the heart. To the lungs, they go through that second to fourth thoracic ganglia. They form those sympathetic nerves after they leave that sympathetic trunk. Splanchnic nerves. That's a fun word to say, splanchnic. Well, these splanchnic nerves, they tend to go through that sympathetic trunk without terminating, without synapsing, connecting to another neuron. They're going to go to paravertebral ganglia, these splanchnic nerves specifically. So we have splanchnic nerves to the abdominal pelvic area. We have the greater splanchnic nerve, which is T5 to T9 or T10. We have a lesser splanchnic nerve, which is around T10, T11. And they're all going to different organs, tissues in its vicinity, in that general area. The lesser, or least, sorry, splanchnic nerve, I just said lesser. Least is that 12th, T12 ganglia. And then we have a lumbar splanchnic nerve. That first four lumbar vertebrae. And it will actually terminate in that inferior mesenteric ganglia. So this is going to the lumbar, going to that pelvic area. These splanchnic nerves that go to the adrenal medulla, they're going to pass through that sympathetic trunk without synapsing. The greater splanchnic nerve and this celiac ganglion will extend to those chromaffin cells in that adrenal medulla. They come from the same tissues, those neural crest cells, which allows them to release that epinephrine and norepinephrine. They do release trace amounts of dopamine, but we get most of our dopamine from within the brain, which is where we come into Horner syndrome. Horner syndrome is the sympathetic innervation to one side of the face is lost. It's usually a mutation that's inherited, but it can be caused from an injury or a disease. So these people have ptosis, which is drooping of that upper eyelid, miosis, that constricted pupil, and anhidrosis, a lack of sweating, only on that affected side, nowhere else. It's interesting. So this parasympathetic, we've looked at the sympathetic, let's look into the parasympathetic. So these parasympathetic, the cell bodies of these, of these parasympathetic are found in nuclei in the brainstem. The lateral gray horn of the second through fourth sacral segments. We have that cranial parasympathetic outflow, which comes off of 4 cranial nerves. They have that sympathetic, or that sacral parasympathetic outflow, which is the second through fourth sacral spinal nerves. They end in parasympathetic ganglia, where they're going to synapse with those postganglionic neurons. At this point, they are either next to or within the walls of their targeted tissue. So 4 pairs of the ganglia are associated with that vagus nerve. That vagus nerve does a lot of things. So it has a ciliary ganglia. That oculomotor nerve gets its parasympathetic fibers from here. Pterygopalatine, that facial nerve gets parasympathetic information from here. So that nasal mucosa, the palate, the pharynx, and the lacrimal gland all get their parasympathetic from the facial nerve. And then we have submandibular, glossopharyngeal, cranial nerve 9, sending information to that parotid gland, which is out near the angle of your mandible, is where you'll get that parotid salivary gland. And that glossopharyngeal nerve is sending that information and getting those parasympathetic fibers in that submandibular ganglion. So that vagus nerve, it does a lot. Almost 80% of the craniosacral outflow comes from the vagus nerve, because it's going to send information to the heart, lungs, liver, gallbladder, stomach, pancreas, small intestine, and part of that large intestine. Again, those pelvic splanchnic nerves are going to have that parasympathetic, the second through fourth sacral nerve is sending that parasympathetic on that pelvic splanchnic nerve. It's going to go to smooth muscle and glands in the colon, ureters, urinary bladder, and reproductive organs. So here's an example with the bladder. We have this parasympathetic nerve that's coming out. It is on this pelvic splanchnic nerve. It is going to synapse at the ganglia that is in the wall of the bladder. And then it's going to go to all the tissue of the bladder to send out that information. So we have cholinergic neurons in the autonomic nervous system. These are what release out that acetylcholine. So all sympathetic and parasympathetic preganglionic neurons are cholinergic. Sympathetic postganglionic neurons that go to sweat glands are cholinergic. And all parasympathetic postganglionic neurons are cholinergic. We have nicotinic receptors. These are at the plasma membrane of dendrites in the cell bodies of sympathetic and parasympathetic postganglionic neurons, chromaffin cells in the adrenal medulla, and the motor end plate of the neuromuscular junction are nicotinic. Muscarinic. The plasma membrane of all effectors, so smooth muscle, cardiac muscle, and glands that are innervated by parasympathetic postganglionic neurons. So this nicotinic receptor here that releases out that acetylcholine, and then we have this norepinephrine being released out because we have sympathetic. Here we have a nicotinic that's releasing that acetylcholine, and this muscarinic that is also releasing out acetylcholine. This is our sympathetic to most sweat glands. Parasympathetic. We have a nicotinic receptor releasing acetylcholine. We have a muscarinic receptor releasing acetylcholine in that parasympathetic division. Adrenergic neurons release norepinephrine, and adrenergic receptors, they bind norepinephrine and epinephrine. So we have those neurons and receptors. So this goes through those cholinergic, nicotinic, muscarinic receptors, those adrenergic receptors, where they're all found and what they do. So an agonist It has a substance that binds to and activates a receptor. It mimics the effect of a natural neurotransmitter or hormone. Phenylephrine is an adrenergic agonist. It's an ingredient in cold and sinus medicine. So what it does is it constricts blood vessels in the nasal mucosa to help reduce mucus production, to help relieve that nasal congestion. Those of you going into nursing will learn some basic pharmacology, and this is some of that pharmacology that you will learn. That name of the drug, phenylephrine, it works on an alpha-1 receptor. You'll learn what receptors it works on, what and what it does. This antagonist is going to bind to and block a receptor, preventing a natural neurotransmitter or hormone from having its effect, like atropine. That's going to block a muscarinic acetylcholine receptor. Dilates the pupils, reduces glandular secretions, and relaxes smooth muscle in the digestive canal. So whenever you go to get your eyes checked and they dilate your pupils, they're going to use atropine. They can use it to treat smooth muscle disorders such as iritis or intestinal hypermotility. So these are just some ways we can actually treat some of these autonomic functions. And then we also have autonomic tone. This autonomic tone creates this balance between the parasympathetic and the sympathetic. The hypothalamus is going to regulate this autonomic tone. So it will turn up sympathetic tone at the same time it turns down that parasympathetic tone and vice versa. So since these two systems, the sympathetic and the parasympathetic, can affect differently, they release different neurotransmitters and cause these different effects. We cannot have sympathetic and parasympathetic running at the same time. It's one or the other. So one gets turned up, the other one gets turned down. So sympathetic gets turned up in a fight or flight type of moment. That parasympathetic needs to get turned down. And that parasympathetic gets turned up when you're sitting down watching TV doing nothing. That sympathetic needs to be turned down. So sympathetic responses. Let's look at what is happening to the body in a sympathetic response. The sympathetic response can be during a physical or emotional stress. Physical, vigorous physical activity like running puts your body into a sympathetic more type of response. It reduces certain body functions that favor storage of energy. We don't, in a sympathetic response, like running, I use running as an example because it technically puts your body into a sympathetic response. You're not trying to store energy when you're running. You're using up energy when you're running. But different emotions like fear, embarrassment, or rage can also give a sympathetic response. People who get anxiety standing up in front of a class to give a speech, that's a sympathetic response. Everything that you're experiencing, that sweating of your hands, increased heart rate, sometimes that lightheadedness, that's a sympathetic response. So during this sympathetic fight or flight type of response, your pupils are going to dilate, get more light in so you can see better, see what's going on so you can run away from something. Technically, a sympathetic fight or flight response is preparing your body to run away from something. So your heart rate goes up, that force of that contraction goes up, your blood pressure goes up, your airways dilate. Larger the airways, the easier it is to get air in. Blood vessels that go to the kidneys and that gastrointestinal tract, your digestive tract, they constrict. We don't need to move things through the kidneys and that digestive tract at this moment because we're trying to get away from something. So it's going to decrease the blood flow and it slows urination formation and digestive activities. Your liver cells are going to break down glycogen into glucose to form energy. Your adipose tissue, those fat cells, are going to go through lipolysis, meaning they break down as well. We release any glucose stored from the liver into your bloodstream. But so we're getting more energy out into our bloodstream to get them into our cells to perform activities. Sympathetic responses, they're pretty widespread and they last longer because, as we mentioned, those sympathetic neurons go synapse out to 2 to 20 to 30 times more neurons than those parasympathetic do. So they diverge more extensively to activate more tissues than parasympathetic. Acetylcholinesterase inactivates that acetylcholine, but norepinephrine has a lot longer effect at those synaptic clefts, so at those neurons. Epinephrine and norepinephrine get secreted into the bloodstream. So something that gets secreted into the bloodstream has an entire body effect to it. So that prolongs that response. Hormones do eventually get destroyed by the liver. They get broken down. But since this goes into your bloodstream, that epinephrine and that norepinephrine, it causes that lasting response. Now that rest and digest, parasympathetic. We've got an acronym for what happens. It increases salivation, increases lacrimation, urination, digestion, and defecation. These are all functions that conserve and restore body's energy to that time of rest and recovery. We also have a decrease in heart rate, decrease in the diameter of airways, and a decrease in diameter of your pupils. So there's a lot. Your body is trying to take up all the nutrients it can. It's forming the urine. It's slowing down your heart rate because you're at rest, not doing anything. So parasympathetic responses are much different. So let's look at some of these different autonomic reflexes. We talked about the pupillary light reflex already, but different autonomic reflexes occur when nerve impulses pass through an autonomic reflex arc. So we're controlling our blood pressure through these reflex arcs. Digestion, defecation, and urination. Blood pressure, you can adjust the heart rate, the force of ventricular contraction, blood vessel diameter. Digestion, adjusting motility and muscle tone. And urination and defecation, you're regulating the opening and closing of sphincters. So just like our somatic reflexes, the autonomic reflex arc is the exact same. So we have that sensory receptor, that connects to that sensory neuron that goes into the integrating center, usually in the spinal cord or the brain, depending on where it's coming from. And a motor neuron sends out information to that effector tissue. It's the exact same sequence. So let's look at how our autonomic nervous system maintains our homeostasis. So, in that integumentary system, contraction of that erector pili muscle, Sweat glands. Skeletal. We have pain receptors in our bone that helps to warn of bone trauma and damage. Muscular. Contraction of skeletal muscles to bring on body movement. That corpus striatum and reticular formation sets that muscle tone. Then we have the cerebellum that coordinates movement. The endocrine system. That hypothalamus helps to regulate hormone secretions from the posterior and anterior pituitary. This you'll learn in anatomy too. That autonomic nervous system is going to help regulate hormone secretion. Cardiovascular system. That cardiovascular center is in the medulla oblongata, or just medulla, and it's going to work with heart rate and that forcefulness of that heartbeat. So nerves from that autonomic nervous system regulate blood pressure, blood flow through those blood vessels. We have our lymphatic system and our immune system. So they're going to help to regulate immune responses. It can increase or decrease those immune responses. Respiratory system. It's going to regulate the diameter of your airways. It can also control breathing rate and depth. Digestive system. We have that entire enteric plexus that regulates your digestion. That parasympathetic is going to stimulate digestive processes while that sympathetic slows it down. Have that twice. Urinary system regulates the blood flow to the kidneys, formation of urine, emptying of bladder. Reproductive, the hypothalamus and the limbic system are helping to control a lot of this, but the autonomic nervous system brings the erection of the penis and the clitoris and the ejaculation of semen. That hypothalamus is going to control the ovaries and the testes, the regulation of the hormones coming from there. And that touch stimuli from suckling from an infant releases that oxytocin to eject milk from the mother's breast. So autonomic dysreflexia. Autonomic dysreflexia is actually an exaggerated response of the sympathetic nervous system. And it tends to occur in people who have a spinal cord injury at or above T6. You can see it after recovery from spinal shock, and it's usually because of this interruption of the control of the autonomic neurons to that higher centers in the brain. So when sensory impulses, such as that stretching of a full bladder, they're unable to go up to the spinal cord, go up to the brain to let you know that you need to urinate. Pain receptors in the visceral from sexual stimulation, labor, delivery, and bowel stimulation cannot make it to the brain. We get increased sympathetic activity that causes vasoconstriction that increases blood pressure. Cardiovascular center increases parasympathetic output, which will decrease the heart rate, decrease sympathetic output, dilated blood vessels above the injury. These people usually have a pounding headache, high blood pressure, warm skin with a lot of sweating above the injury, and cool skin below. They have some pretty high anxiety as well. The first thing they have to do is remove that stimulus, that hypertensive drug. If it's left untreated, these people can have seizures, stroke, or a heart attack just because of all of these symptoms that are being caused. Another one, Raynaud's phenomenon. This happens usually in the fingers and the toes. and it's where the blood vessels actually spasm and close off blood supply to the fingers or the toes. They become ischemic. That lack of blood supply, those blood vessels spasm and close. It can happen after exposure to cold or emotional stress. And it is because of excessive sympathetic stimulation of smooth muscle in the arterioles of the digits. And it's causing that vasoconstriction, that closing off of those blood vessels. So they have this complete lack of blood supply. The fingers can look completely white, left long enough, they start to look blue. In extreme cases, those fingers can become necrotic because of a lack of oxygen. There's ways you have to rewarm after cold exposure. Those arterioles will eventually dilate. The interesting thing is people with Raynaud's tend to have a very low blood pressure. I have Raynaud's. My blood pressure usually, I've scared people with my blood pressure before. The lowest I think it's been is 96/62. I've scared people with that blood pressure. Some people have increased alpha adrenergic receptors. It is common in young women and people who are in cold climates. So people with Raynaud's should avoid cold weather, wear warm clothes, and keep their hands and feet warm. This is my hand. This is probably September or August time of year when this picture was taken, which is kind of, it's still warm out. Maybe into October. It's just where the temperatures are just extreme enough that my fingers start to vasospasm. The interesting thing is treatment for this, which insurance companies are yet to cover, is Viagra. Because Viagra is a vasodilator. It prevents those vessels from spasming and closing off. So here, these blood vessels are spasmed and closed off, and your fingers turn completely white. As the blood starts to come back to the fingers, they turn like a deep purple because blood rushes into the area. You can see even how in the fingers, they are actually starting to kind of get that pruny type of sensation because there's no blood supply in those fingers whatsoever. So thank you very much for listening and have a wonderful day.